The views and opinions expressed in this podcast are those of the hosts and their guests, and do not necessarily reflect the views or positions of scholars in medicine or the guests or hosts' institutions or employers. Content has not been reviewed to confirm accuracy of dosing or other recommendations. Viewers should confirm via independent research before implementing and recommendations in patient care.
Welcome to Derms on Drugs, a new video podcast brought to you by scholars in medicine. Derms on Drugs is where cutting-edge derm meets mediocre comedy. I'm Matt Zyrus, and each week I'm joined by my residency buddies, Laura Ferris and Tim Patton, to discuss, debate, and dissect the hottest topics in dermatology. It is everything you need to know to be on the cutting edge of dermatology, and it'll be the most fun you've ever had while actually learning something useful. So Tim, Laura, and I have been buddies for 20 years. And what that means is that between the three of us, we've got 60 years of experience. Laura is now the chair of dermatology at the University of North Carolina. Tim stayed at Pittsburgh, where the three of us trained, and he's been faculty there for 20 years. And I'm a private practice dermatologist in Columbus, Ohio, who spent 15 years in academia before making the jump to private practice. So we've got a diversity of wide experience, and we can't wait to tell you what we think about what's happening in the world of dermatology. So we are going to go ahead and get right into it. Now, I do want to remind you, tune in every Friday whenever new episodes are going to drop. But the setup of our show is divided into three segments. So the first segment, we are going to talk about the three articles that we thought were the most interesting things in dermatology for the week. We're going to call that the Big Three. After that, we're going to go into a deep dive where we're going to have a guest on who's going to talk about an interesting topic, something that we thought was hot and going on in the literature. This week, we are super excited to have Dr. Ted Lane, who runs a meeting called The Science of Skincare. And I'm going to tell you, you're going to want to stay around for that interview because me, Patton, and Ferris, we are not such believers in that there's much science behind skincare. So we're going to see if Ted is able to convince us differently. And then after our deep dive section, we go into the six pack, where we're going to be talking about 6 more articles that we thought were interesting and impactful for the week, kind of the way that we would sit around and share a six-pack and BS about what's going on in the world of derm. So with all that said, let's go ahead and get into it. So the first article that we are going to talk about today is a really important one, and it comes from AbbVie. This was published in the British Journal of Dermatology. It's the efficacy and safety of upadacitinib versus dupilumab in adults and adolescents with moderate to severe atopic dermatitis. The week 16 results of an open-label randomized efficacy assessor blinded head-to-head phase 3B/4 study. The primary author was Dr. Jonathan Silverberg, and you may have heard of this study from your AbbVie rep. It's called Level Up. And so first, the big reason that I really wanted to talk about this, AbbVie is really making a lot of noise around this, really educating us about it, because the takeaway from the study is Rinvoq worked better than Dupixent, right? Now, so AbbVie really wants to push that home to us, but I'm here to tell you that while this was a very well done study, it added approximately 0 to our knowledge about these two drugs. Now, I'm going to explain why that's the case as we go forward. And really, it's because we already had a head-to-head study of dupilumab versus Dupixent versus Rinvoq. It was done before Rinvoq launched into the market. It was called the Heads Up study. That study showed us that Rinvoq 15 worked faster than Dupixent, but they got to the exact same point. They had equal efficacy at 16 weeks. And it showed us that Rinvoq 30 milligrams got about 10% more people to treatment success than did Dupixent. So we already knew that Rinvoq 15 about equal to Dupi. We knew that Rinvoq 30 was a little bit better. AbbVie redid this study, though, because they weren't allowed to use that heads-up data promotionally. So this study was really designed to be on-label use of Rinvoq versus on-label use of Dupixent. So patients had moderate to severe atopic dermatitis, yada, yada, the normal stuff. And then they were either started on Rinvoq 15 milligrams or they were started on Dupixent. After 4 weeks, if they hadn't gotten substantially better on Rinvoq, both in terms of the appearance of the rash and the itch, they were dose escalated to 30 milligrams. At 8 weeks, if they weren't doing really, really well on the 15 milligrams, they were dose escalated to 30 milligrams. And then we looked at our results at 16 weeks. So the reason this study didn't tell us anything new was that about 70% of patients dose escalated to 30 milligrams. And so more or less, this study was, again, looking at Rinvoq 30 milligrams versus Dupi. And the real thing that we need to know is, how does Rinvoq 15 compare to Dupi? Well, let me give you what the results of this showed. So first, I already told you about 70% of patients dose escalated. Now, of the patients who started this study, right, so 400 and some patients started the study on Rinvoq, about 10% achieved the primary endpoint, EASI 90 plus worst itch, NRS score of 0 or 1. About 10% of the people who started on Rinvoq 15 achieved that endpoint on Rinvoq 15. Of the people who got dose escalated to 15 milligrams, about 14% of them achieved the primary endpoint. So we assume that all of them, are people who would have achieved it, the people on 15 would have also achieved it on 30. So we could really say about 24% of people on Rinvoq achieved the primary endpoint. But again, only 10% of those who started on 15 achieved the endpoint on 15. All right, now for Dupi, it's about 9% of patients achieve the primary endpoint. So again, it looks like Dupi and Rinvoq 15 pretty similar to each other. There's a lot of issues with making that comparison that, you could nitpick me on, but really ended up looking about the same. And again, Rinvoq 30 milligrams got a little over 10% more people to the primary endpoint. Okay, great. So really didn't tell us anything new. Reconfirm for us that if you're willing to go up to 30 milligrams of Rinvoq, you see better efficacy than you see with Dupi. The other couple of interesting things in here, it reconfirms safety profiles as well. So Rinvoq, as we now know, there is no cardiovascular risk, there's no thromboembolic risk, there's no cancer risk. None of those things have shown up in the data. We've got like 30,000 years of patient exposure, and they didn't show up in this study either. But about 2.8% of people, so that's about 1 in 40, got either zoster or eczema herpeticum. And so a significant number of people, this is why everybody that I start on a JAK inhibitor for atopic dermatitis, I put on prophylaxis with 500 milligrams of valacyclovir. That's going to protect them both from shingles and from eczema herpeticum. Now, if we look at the Dupi safety, first, about 8.5% of Dupi patients got an eye issue, 1.5% of Rinvoq patients, so difference of 7%. We already knew that. 7% of people on Dupi get an eye issue. And then arthralgias. So 2% of Dupi patients got arthralgias, 0.9% of Rinvoq patients. So it was about 1%, 1 in 100 people on Dupi got arthralgias. And we already knew that that number was in that range. And so overall, the study confirmed for us a lot of things that we already knew, but didn't really add anything other than solidifying those things that we already thought. So Tim, Laura, what do you guys have to say about this?
I guess you think they're about the same.
Yeah,
they're about the same. But I think you could argue this is more real world use, right? Because you start with 15 in the real world and then you dose escalate up to 30. I guess it gives you more safety. I would agree. I don't know if this is like the most illuminating study, but I think that if you asked AbbVie, their argument would be, well, this is, the way that it's going to be used in the real world. And so we could show that there's benefits to dose escalation.
So how many patients would the two of you say in your real practice that you start on Rinvoq, you end up dose escalating? Patton?
I have no idea. I've done it, but maybe
So-
yeah.
Give me a guess.
Not most of them. Not most of them. Let's say that.
Yeah, that's exactly it. Ferris, how about you? I'd say 10, 20% of the people I start on Rinvoq, I end up dose escalating. Is that about what you would say?
Yeah, it's about, I was going to say 10%.
Okay. Yeah. And so this, right, 70% of people dose escalated. So it's not really real world use. The other thing, though, that was really kind of interesting, about 2.5% of people on Rinvoq got either eczema herpeticum or zoster. 2% of Dupi patients got arthralgias versus 0.9% on UPA, so it confirmed the arthralgias for us. And about 8.5% on Dupi got eye issues versus 1.5 on Rinvoq. So about 7% of people got eye issues. We already knew all of that. So really didn't give me a whole lot more information. And the main reason I wanted to talk about this today is because AbbVie's making sure we all hear a lot about this study. And I want people to really understand what it shows. It reconfirms for us Rinvoq's a little bit better of a drug if you go to 30, but we still don't really have a comparison of Rinvoq 15 compared to Dupi. So let's go ahead on to our second. Pat, you got something you want to say?
Well, didn't you think this was we're going to prove that Rinvoq's better and everyone's going to use Rinvoq before they use Dupi because it's better? And I don't think derms are going to do that.
No.
You don't have blood work. You don't have eczema herpeticum. You give them the shot. It's only every 2 weeks. They could say that it's so much better, but so many patients on dupilumab come back and they're the happiest people in the world. I'm not going to go to Rinvoq first, right?
What
I don't think you can by the label. I think you can't.
Matt,
I think you can.
Yeah.
They don't have to have failed a biology. They can just have a shot of Kenalog. And when I consult with AbbVie, I keep telling them, you're barking up the wrong tree. You don't need to prove to people that Rinvoq's more effective. You need to make people more comfortable with safety.
Yes.
And that's what's going to change behavior, right?
Yep.
But all right, so Ferris, let's go on to your article.
Okay, so my paper is in JCI. And so this was a paper by Oka et al. And this was talking about Th2 cell-directed immunotherapy eliminates actinic keratoses. So what was this? This was a paper looking at treatment of actinic keratoses with calcipotriol and 5-FU. And so what they showed here was that this actually leads to the generation of resident memory T cells. And so I think that this is a very, very basic science dense paper that I cannot cover in 3 minutes, but kind of key takeaways here. So one, there was an open label study, 18 patients, 6 days, a BID application of the combination of calcipotriol plus 5-FU, and they showed reduction of, mean number of AKs, 95% on the face, 82% on the scalp, 65% on upper extremities. What I think was interesting is, one, they looked at mechanism. It's actually Th2 mediated. That is not something that we think about as being how we protect from cancer. They showed that IL-4 and IL-13 were necessary, and also IL-24 mediated as well. Now, what I thought was really interesting was they actually did this study 5 years ago where they treated patients with either 5-FU with Vaseline or 5-FU with calcipotriol. And they showed better efficacy against AKs, but they went back to those patients who had just been in that study, had not had a subsequent AK treatment, and then they biopsied their the AKs that they had, and they actually showed a big difference in the AKs in those patients who had had the calcipotriol as opposed to those who just had 5-FU alone. More resident memory T cells, and upregulation of class 2. So I think that this is interesting because it would suggest that this is, and they also showed that with this combination that you reduce the number of squamous cell carcinomas that form in a 3-year time period, better than the data that we have for 5-FU alone. So I think that this is really interesting. It suggests that this is really working differently. It's just shorter treatment for patients, and it also suggests that we can reduce the number of squamous cell carcinomas.
So, Ferris, this completely changed for me. So I had we've kind of known for a while, right, that 5-FU plus calcipotriol was probably the most effective AK treatment that we've got. But I had always assumed that it was basically the calcipotriol was causing some irritation that then allowed the 5-FU to penetrate better. No big whoop, wasn't excited about it. Actually didn't do it because I was like, I'll just have them use the 5-FU for longer. I'll do whatever. This completely changed the way that I think about this therapy. And I think I'm going to actually start to use it Like, is this what you've been doing for AKs? Is it what you're going to start doing for AKs? Is this going to affect how you practice?
I have liked this for AKs for a while. I do think it works better. I think that the shorter duration of therapy is great for patients. I like that now I actually sort of have data. I thought it was interesting to call this immunotherapy, but I guess in a sense it is. To me, the hardest thing is like my AK patients are older. This is a compounded medication. Trying to get them to a compounding pharmacy, it's silly, but that's like the biggest challenge for me of using this. But if I talk them through it, this is my first choice, and it's a very cost-effective, data-driven therapy as far as I'm concerned.
Patton, you use this?
I've used it. I still use 5FU 2 to 3 weeks more often. I don't have a good reason for that. It's probably just a habit. The compounding, man, I mean, like a lot of them are just like, we'll call the patient, we'll deliver it. I haven't run into that being a difficult thing. They're part of our electronic records. We send it right in. It's actually pretty straightforward.
I don't know. Old people are just hard. Old people are hard. I mean, I get because if they don't answer their phone, then
fine.
They're done. You're done.
Or they're not comfortable giving a credit card to buy something. I mean, these are like the times that I get, hung up on it. But honestly, with the right patient who can, navigate that, I think that this is a great option, and it's faster and it works.
I like
better.
it. I don't know why I'm holding on to my old ways.
Do they get ulcerations like a 3-week 5FU thing?
They get vigorous responses, and it varies by person, like it does with 5FU. I don't find that they get worse. Like I don't find that they get less tolerable.
All right, we're going to have to get Ted's opinion on this when he comes on, because with him being in Texas, I would imagine he treats more AKs in a week than the three of us have treated over the course of our careers. But so let's jump on to our third paper. Patton, what do you got for us?
All right, so paper by Sumarai et al. From October 2024, issue of Health Affairs. It was a review of 11 studies that had various measures related to pediatric depression over a particular time period when the FDA issued an advisory and then a black box warning. So the advisory was in 2003, black box warning was in 2005. And what it says is that in children, adolescents, and young adult patients, increases in suicidal thinking and behavior can occur. A lot of those warnings do elaborate that patients should be watched closely for any changes in behavior. And so they were looking at things that happened around that time as it related to pediatric depression. So Exhibit 1, depression diagnoses and visits for depression were slowly increasing before 2003, and then after the black box warning, they decreased. This I thought was the oddest chart. Why would black box change visits? I could see it affecting prescribing habits, but actual visits to psychiatrists. So was there something else going on that maybe affected the second two charts?
Come on, Pat. Come on. Here's what happened. The pediatricians don't want to talk about depression. As soon as this came out, if they bring up depression, now they got to do something. They don't want to prescribe the SSRI. They don't want to send them to psych.
So the patient's going to be like, I am depressed. And the guy's going to be like, I am not listening to,
you've got like 9 kids. You've got 9 kids. There's no way. He doesn't really have 9, but he might as well. They're not going to tell anybody they're depressed, right?
But the diagnosing changing, I just don't get it. Let's move on. Exhibit 2. Okay. This was looking at rates of antidepressant treatment among pediatric patients. Now, the text of the paper says that antidepressant treatment and use declined anywhere from 20 to 50%. But what's weird is the one line, it's percent antidepressant use. It rises slightly before the warning, starts to decline after the warning, but then it starts to increase again. And it's actually higher at the end of the graph around 2010. So the decrease, I guess they were referring to those other 2 lines, which were prescription fills and percent antidepressant initiation. So maybe that's where they got the decreases. And then Exhibit 3 finally was increases in psychotropic drug poisonings, which was a proxy for suicide attempts and suicide deaths following the FDA warnings. Whereas before the FDA warning from 1990 to 2003, when SSRIs became available, those appeared to be declining. So the visits and diagnoses don't make sense to me. I get what you're saying, Matt, but I'm skeptical of that argument. What was most concerning, and authors conclude FDA should revisit the black box warnings. It's actually harming patients, these warnings being present. What was most concerning to me, the article mentioned, fewer than 5% of pediatric patients were monitored in accordance with the FDA's recommendation, and there was no change in that. So the warning didn't increase appropriate monitoring, which I think the FDA thought, well, this will be helpful. But I also want to say it's like doctors were kind of like, forget it. I'm not prescribing these medications. And that's like the doctor's fault. And yes, the FDA affected that. But I think of the black box warnings that we have. I mean, I think that was kind of the focus where we wanted to go with this paper, not to discuss pediatric depression the whole time, but topical calcineurin inhibitors in risk of lymphoma, brodalumab in depression. Other IL-17s don't have that depression black box. Topical ruxolitinib, TNFs with infection and malignancy. But, my takeaway is black box warnings don't really mean a whole lot to me. They are there and you have to address them. And if you're a good doctor, you are aware of them and you address them. But aside from black box warnings, the internet and media and TikTokers saying propylparabens and CeraVe cream and, our sunscreens are going to turn males into females. We have to deal with so many other things. The black box stuff, to me, it's not a big deal.
See, Pat, you're in your ivory tower. You got to remember that for those of us out here in the real world, we've got like 7 minutes per visit. If there's a boxed warning that they're going to get from the pharmacist that says this might make you think about suicide or this might give you a heart attack, now I got to talk to them about it, because if I don't, they're going to get it and then call me. And so the box warning forces you to have conversations that you may or may not think you have to have. And in the real world, that's a big difference.
But so, methotrexate, one of the black box warnings.
Yeah, you're right.
Death. It's death. That's the worst side effect.
And how much methotrexate do dermatologists use?
We use a lot of it. I mean, we still have to, unfortunately, because of the insurance situation. Before you want Dupixent, they have to fail methotrexate. I have never gotten a call. This can kill me. I don't specifically mention death as a side effect. I talk about liver and, they sound bad. It's not like I don't address it at all, but I specifically do not say death is a potential black box side effects. Good luck. I don't know. Ferris, what do you think about black box stuff?
About black box, I give some risk. I cannot go through the whole black box on every single drug. So if it has a black box warning, I will say, if you read about this, you're going to read about some of the risks that include blank. I almost never use the term black box unless I'm dealing with a very sophisticated patient who I think is going to need to know that. So, it's part of it is like, they're going to go read things on their own. Part of it is I need to have some sort of medical legal documentation that I discussed risks. But I agree. I think it's still incumbent on us to make sure that we give patients the best treatment and give them appropriate counseling, put risk into perspective. It's a really hard thing to do. I think where I come up with, needing to do this is not a black box issue, because I do a lot of psoriasis, is IL-17. So I talk about inflammatory bowel disease. And, when I say this will happen with, inflammatory bowel symptoms in about 1 out of 1,000 patients, like I try to give them a number, not like, oh, most people get this. I think, if we have those numbers for things like MACE events or lymphoma, that's helpful to put into perspective for patients too.
All right, let's go ahead and move on to the next segment of our show. Our deep dive. And so I'm going to introduce our guest, Dr. Ted Lane, who practices in Texas, as I mentioned, as part of Sonova Dermatology. Ted, great to have you on the show.
It's a lifelong dream. Thank you so much for having me, guys.
You got what? Ted, let's get right into it here. So you run a meeting called The Science of Skincare. Mm-hmm. What made you start that meeting? So to me, skincare, there isn't a lot of science, it's a lot of art. And that doesn't mean that it's like art is art's really important and hard to do. So that's not like a dig of like, well, but it'd be like saying the science of, Renaissance paintings. Like, why did you start the science of skincare, and what do you guys talk about at the meeting?
Yeah, so this started in 2021, right, during COVID, where I was, at home, not much to do, thinking about my life. And I realized, I had spent a lot of time with skincare just because it's a subject that's really interesting to me. We talk a lot about skincare in our medical practice. We use it for moisturizing, cleansing, for our inflammatory skin disease. And yet we don't know much about it, right? We don't understand the ingredients. We don't understand the science behind the formulations, nor do we understand the layering and all the different science and chemistry that underpins topical formulations in the OTC space. So I just started to do some research on my own and realized how important it is and how nobody was really giving us any education on this, especially during residency. I don't know, Laura, if you do at UNC now, or Tim, if at University of Pittsburgh you guys have any formalized education on skincare. I certainly didn't, and it was not very easy to find it at conferences that were supposedly, medical conferences or aesthetic conferences. You may get an hour here or there. And so I called up a buddy of mine who was Patty Ferris, who's kind of a worldwide expert, known for many years as one of the seminal figures in skincare and nutraceuticals. And I said, Patty, I think we should start a meeting. And she said, great idea, let's do it. I didn't think she was going to say yes. So we kind of started right in the middle of COVID in New York City during their marathon weekend. And again, just so naive, we had no idea what we were doing. But it's kind of, there was enough people that were interested and enough companies that were interested, and they kind of gained a little bit of a footing. And the Science of Skincare Summit is, we're entering year 5 in 2025. So look, I think to your question though, Matt, the idea of science underlying skincare is actually there. There's double-blind randomized placebo-controlled trials done primarily by the larger companies, your L'Oreal's, your Galderma's, your Beiersdorf's, your Pierre Faub's, for example. But more and more companies now are finding the funding to do that as well, especially at a young age. And furthermore, I think the science of skincare is actually outpacing the science of medical derm. So if you look at, for example, the regenerative area or longevity area, whereas previously we thought about kind of longevity medicine as at the fringes, my gosh, it's so front and center now as Peter Attia has come out with his book, and then we listen to all these different podcasts. And
well, there's that guy on Netflix who says he's never going to die.
Yeah,
right?
yeah, that guy as well. Right. Brian Johnson,
well,
yeah.
Ted, let me jump in and ask you. So me, Patton, and Ferris, when we trained with Susan Obashi, we trained with a very good
there you go
aesthetic person. But what I have never been able to get answered, and I think Patton and I and Ferris maybe as well, have always been like skincare is baloney, because like the key product that's always been around, TNS serum with growth peptides cannot penetrate the dang stratum corneum. So, and nobody's ever explained to me how the heck that works, because if it's more than 5 amino acids, it's over 500 Daltons and it can't penetrate. Yeah. So do they know how peptides work?
Oh, such a great question, Matt. So TNS serum, let's take that as an example, right? And remember, it's 25 years now. They've just celebrated their 25th anniversary of TNS, and they've advanced the formulation a couple of times. But TNS, initially when it was out, they were talking about growth factors. And of course, growth factors are gigantic molecules. There's absolutely no way that they're going to penetrate the stratum corneum. And yet people were seeing a difference. I mean, people were paying $250 for this serum.
It's got to work. It has to work.
Anecdotally, it has to work. And we have some data to show it works. Well, now we're thinking that it works because not necessarily due to the growth factors, but there are exosomes in there as well. Exosomes are essentially liposomes, and they contain various things, but they can contain amino acids, very small growth factors. They contain microRNA. They can contain very small peptides, all of the above. And because they're at the nanoparticle size, they do penetrate. And now the thinking is, okay, this growth factor serum is actually an exosome serum, and that's why we're seeing some of these results. Now we have the flooding of the market of these different exosome products, which I'm sure you guys have seen from multiple manufacturers. It started overseas and now is kind of penetrating into the U.S. market. And we're starting to see some interesting studies based on exosomes.
So you're telling me exosomes are a real thing? Because generally when I hear exosomes, what I mainly hear is, that sounds like crap. Do they really like make chip penetrate?
Okay, so exosomes are a real thing. They have been shown to penetrate. We do know they penetrate.
Okay.
You know, they're liposomes, right? So we know
Yeah.
liposomes penetrate. So
But
that's
you heard
not,
a lot about liposomes like 20 years ago, and then it never turned into anything.
yeah. So these liposomes, though, have biologically active ingredients. Now the problem is, you know, exosomes can be derived from various different cells: mesenchymal stem cells, adipose-derived, platelet-derived, umbilical, Wharton's jelly, you name it, and there's a company that has an exosome derived from that tissue. Now, there's an exosome war out there to say, you know, because we're derived from mesenchymal stem cells, we work better in the skin versus others. And there's plant-derived exosomes as well. I mean, I could go on and on.
Yeah.
But I think what we need to do, though, is, you know, and study, and companies are starting to do this now, is just get more randomized trials out there, because there's so much pseudoscience, there's so much hype behind it. We need to get the science behind the skincare, and we're starting to see that now.
Okay. I'm kind of I don't want to completely monopolize talking to you, Ted. So, Patton, what do you got, Patton?
My most skeptical approach to these is, you know, I'm seeing immunobullous patients and I'm trying to arrange for, rituximab and a immunobullous patient that his oncologist doesn't want to treat his metastatic renal cell carcinoma because of bullous pemphigoid. And I'm like, I can treat this pemphigoid. Sure. And then you have a patient that comes in and is like, what do you recommend for skincare? And I'm like, I use gentle things and put sunscreen on and maybe a retinoid at night. Goodbye and thank you. And they look at me, you know, you have the patient that looks at you in horror and was like, I just moved here from New York and my dermatologist there had me use a special wash in the morning followed by 3 different creams, one of which used a natural sunscreen. And then I applied vitamins and acid and fish semen. And that's not a joke, right? There is a thing derived from salmon sperm.
There
correct?
Is. Yeah,
right.
PDRN, polynucleotides.
Right. So,
yeah.
And they look at you like you are this horrible dermatologist. And my take is, the horrible dermatologist is the one who told you to spend all that money to put all this stuff on your face to get what is probably clinically going to be of very little difference. So, right, I mean, that's my meanest, most skeptical take. Am I crazy for thinking that at all, or is there something there?
No, there's definitely something there. I mean, I think if you focus on the ingredients that have the most data behind them, so you've got your alpha hydroxy acids, your antioxidants, your retinoids, obviously your sunscreens and your moisturizers, you're not going to go wrong, right? Except for that patient who is so sensitive that cannot tolerate a retinoid, there are alternatives to that. What's interesting now in skincare, and this is why I say it kind of outpaces medical derm, is where previously we've relied on these legacy ingredients to affect change in the skin. What we're seeing now is a focus on the hallmarks of aging, particular cellular senescence. And if we focus on decreasing the load of senescent cells in the epidermis and dermis, not only do we achieve kind of improvement in the skin health and skin beauty, but we may also achieve an improvement in inflammatory disease. So that's where that Venn diagram of skincare and pharma start to overlap. And you guys know this. There's no innovation in topical pharma right now, right? Nobody wants to.
You can't make enough money.
Yeah. Aside from Vtama and Zoryve now, I don't know that we're going to see anything else because it's so difficult to get any payer to cover it. And so we have to turn to OTC skincare to help with these patients. And whereas, you know, we've tried these pharma drugs, now we're trying OTC skincare. And I think we're going to get there based on this novel mechanism of action and targets that skincare is going after.
Ted, are you in Houston or are you in Austin?
I am in Austin. Okay.
So see, Patton, part of it is probably just that people in Pittsburgh and Columbus probably don't care as much about how they look as the people in New York and Austin and Houston. I think a lot of it's got to just be driven by what patients want whenever they walk in the door.
They still ask the question, and I just kind of feel like, you know, you start looking at it and you see exosomes and antioxidants, and I'm kind of like, I don't know that this is going to make it. Like, don't spend $400, $500 on these products.
Unless you're a billionaire or a millionaire, and that's like nothing to you. Right?
Yeah. You know, look, Tim, I hear what you're saying. This is why you should come to the conference, by the way. But
I just got an invite.
There you go. But, you know, these same patients are paying for NADH infusions and peptide infusions and going to their wellness doctor and getting all these unproven taking, microdosing sirolimus and microdosing GLP-1s and doing everything that, taking metformin 500 BID, everything that people are doing right now, right?
Yeah.
With little data, really.
Yeah.
And so, people want to live longer. They want their health span to equal their lifespan to equal their skin span. And so you're going to get more and more people with all sorts of different diseases coming to you worrying about their skin. And so it behooves us as skin specialists, in my view, to understand what's going on with skincare.
Ted, I like the term skin span. Haven't heard that before. All right, Ferris, what do you got? What do you want to ask Ted?
So I'll be the nice one here, Ted. I'm not gonna
come at me, Laura.
I'm nice. I'm nice. I have a
but no. So I'm gonna ask you, like, what's up?
No. Ted's just skeptical. He's nice but skeptical.
Okay, no, nice but skeptical. All right, so I'm gonna leave us on a high note. So if for the person who maybe is sort of the average practicing dermatologist doesn't want to have to stock a lot of stuff or have a lot of upfront costs, wants to be able to say, I don't want to do skincare all day long, but I want to have some good options for my patients. When they say, do you have any products, maybe be able to provide them. I guess my question would be, what would you say to those dermatologists? And then the other flip side of that is, how do you see like product sales evolving? So it used to be, you had a glass cabinet of stuff in your office, right? And you would offer that. Is that still how this is done? Because admittedly, I've been in academia a long time. Like, do you walk in and people buy stuff off the shelf, or are there, things like Amazon type storefronts where you can have virtual inventory, or how does that all work now?
Yeah, so there are companies out there which will put up a storefront for you on the web and then handle all the back office shipping and keeping it all on their shelves and none of on your shelves. So your working capital is not tied up in inventory on your shelves. You can offload that to a third party. Of course, then you make less money on a sale, but it also solves for many of the issues that you talked about. Most of the time, patients come in because they're so used to purchasing on Amazon, and again, this is why Walgreens and CVS are having such a hard time. They don't really expect to buy something in a brick and mortar, and it's okay for it to be shipped. So you don't have to have that much inventory on your shelves. You don't have to have that glass cabinet. Although merchandising skincare is always helpful, especially if people are in your reception area and have some time on their hands. In terms of what products you should carry, again, Laura, I think that depends on what era you want to practice in. If you are more interested, and I don't mean that in a pejorative way. I'm sorry if that sounded like that. Not at all.
No. I'm probably in the 20 years ago era, so that's okay. Fine.
So, and that's where most of us are, right? So
Patton still uses tar.
Yeah.
All the time.
If you are interested in kind of what I call the legacy ingredients, and you would focus on, your sunscreens, your antioxidants, your retinoids, your moisturizers, that kind of thing. If you wanted to practice more on the cutting edge and offer that kind of skincare, then you're looking more at the regenerative techniques. And so you're looking at your peptides, your growth factors, your stem cells, your exosomes. So I think it just kind of, and then obviously there's a gray area in between.
Ted, is there something that is truly better than if I can get them to get to 0.1% tretinoin, a good, alpha hydroxy, and good sunscreen, which the tretinoin, right? The problem is their face just lights up. But if I can get them to that, is there something that's actually meaningfully better?
Matt, I don't have head-to-head trials, right? Which of course I'd love to do. But I can tell you that, I'm lucky to be involved in a lot of different skincare trials right now. And so we have these different skincare products that are being made by both large and very small companies. And it is amazing to me what is happening to the skin with a novel compound with a novel ingredient. Okay. That is absolutely not a retinoid.
Okay. All right. Yeah, well, Ted, I want to thank you for coming on. We will have for everybody on the Scholars in Medicine and the Derms on Drugs website, the link for Ted's meeting, The Science of Skincare. It actually does sound like a pretty cool meeting. And Ted, I really want to thank you and I did promise I would ask, what is your take on calcipotriol fluorouracil?
You know, I was listening to that, and it's interesting. I have been hesitant to offer that combination primarily for medical legal reasons, but also because, you know, as you guys mentioned, getting somebody in the Medicare population to answer a phone call or agree to pay for a compounded medication has been difficult in my practice.
Okay.
So I've steered away from it, but that data that Laura talked about in regards to those resident memory T cells and the decreased incidence of squamous cell cancer 3 years later is compelling.
Okay.
And so it may be something that I turn back to, although I really like, you know, PDT and I get along really well.
Okay, fair. I know George Martin, who lives on Maui, and again, he's is treated, I'm sure, 50 times more AKs than he's a big PDT guy as well. And so I do. While I've not done much PDT. People who I respect do. Is the way that I would put it. Well, Ted, again, I want to thank you for coming on and joining us today.
Thanks, guys.
Really was a fun conversation.
Hey, I appreciate it, guys. Best of luck with this. It's great.
Thank
you.
All right.
All right. So now, before we get on to our final 6 papers here in our 6-pack, Patton, did you put together any trivia for us today?
I did, and I tried to kind of stick with the theme. Ted, if you want to hang out and do three trivia questions before you head out.
Oh boy, here we go. I was not ready for this.
This
Always
is good.
a surprise.
I think you'll kill it. Usually what we do is have the guest and Ferris go up against Cyrus. He thinks he's the smartest dermatologist in the world, and we just like to prove him wrong.
Thanks.
Okay,
Laura, you're on
here
my
we
team.
go. First question. In their song, this is like a little carryover. In their song, She Don't Use Jelly, the Flaming Lips sing that they know a girl that will make you toast, quote, but she don't use butter, and she don't use cheese, she don't use jelly, or any of these. She uses what?
Vaseline.
Yes!
No, margarine. Oh, no, Vaseline. It is Vaseline. All right.
Patton, you are making questions up just so that I will have no clue. What the hell kind of a question is that?
I didn't think I had a follow-up about Robert Chesborough and how he came to discover it was the same answer. Vaseline was the same answer. I figured I would have to go on to that. Ferris, I'm impressed.
That question was like a random word generator to me. I have no idea what the heck you were talking about.
It's you got to follow along very closely. I need to practice at this. Maybe
Okay.
I knew the song. That's all I got.
Okay, I'm
All
impressed.
right, I think the next two are more clearly asked. Okay, number 2, Procter & Gamble began to market cleaning agents on radio programs in the 1930s. These daytime drama radio programs eventually became to be
Soap
called
operas.
What? Yes,
Soap operas.
soap operas is correct.
All right.
I didn't know we could answer the question before the question.
I
was
think
there's no
done.
I
rules.
think Ted knew that one.
There's no
I think
rules.
he knew that easily.
He's
So-
polite.
I-
That's polite.
You
And
can
Matt's
come
not.
in.
Gloves
You
are
can
off.
come in.
Let's go, Patton.
That's right. Rule is there are no rules.
That's right.
No.
Okay, ready? Final one. As a defense mechanism, the bombardier beetle, stick with me, the bombardier beetle can eject a hot, toxic substance containing a mixture of hydrogen peroxide and this skin lightening agent.
Hydroquinone.
Hydroquinone. I think Mac, I'm going to call it a tie. So today's a tie.
Okay, I was thinking about going kojic acid.
I was thinking kojic as well, so I'm surprised it was hydroquinone.
Yeah, that's it. What's the beetle
That's
doing?
what
Trying to
happens
make
when
it.
you practice 20-year-old skincare. You know things.
There's a BBC video. He totally cooks an ant. It is something else.
See, I didn't know if he was trying to get rid of the dark spots, and then the predators would be going to the clubs and having too much fun, something like that.
It's my kind of beetle.
Purely.
All right.
All right.
All right. Well, thanks for sticking around, Ted.
Thank you, Ted.
That was worth it. Thanks, guys.
All right, so let's move on to our 6-pack. So the first article that we've gotten here was one that I picked. So JAK inhibitors. It was from the International Journal of Dermatology, infection risk with JAK inhibitors in dermatoses, a meta-analysis, and then a commentary called JAK inhibitors unveiling varicella and herpes risks in atopic dermatitis. And really the interesting takeaway here is that JAK inhibitors are not generally immunosuppressive. So you don't see a general increase in serious and opportunistic infections, you see very specific things. You see an increased rate of upper respiratory tract infections. You see an increased rate of zoster, and you see an increased rate of eczema herpeticum, but only in patients treated for atopic dermatitis. In patients treated for rheumatoid arthritis, alopecia areata, whatever else with JAKs, you don't see that. So that was kind of the interesting takeaway for me, is that it's a very targeted immunosuppression. And the real clinical takeaway for me from this is that because of the eczema herpeticum risk, because it is not an insubstantial risk, I actually put everybody who I started on JAK inhibitor for atopic dermatitis on valacyclovir, 500 milligrams once a day. Even if now they should be vaccinated for zoster if they're over the age of 50, even if they can get vaccinated after they're already on it, that's fine. But I put everybody on valacyclovir because the zoster vaccine doesn't protect them from the eczema herpeticum. That's kind of the takeaway that I had. Either you guys have anything you want to add kind of about JAKs and infection risk?
So, one, you can actually give the zoster vaccine to people who are younger, who are going on, quote, immunosuppressive medications. So
in
you
theory,
can.
but insurance sucks. So trying to get
Yeah,
that covered.
in theory you can, and they should actually cover it. But, in reality, it's 2 shots. I'm over 50. I still only got one because I haven't bothered to go back. So it's hard to get people to follow through with it. Two, I still wonder about the eczema herpeticum. I think most of that data is in patients who have inadequate response, like who have uncontrolled atopic dermatitis. So did you see, was it related to the control of their AD? Like, do the people have great control of their AD and still get eczema herpeticum?
So I would say, just my clinical experience, because I haven't really seen the data presented that way, I've seen about 10 cases of eczema herpeticum, and I would say that I see it in people who are doing really good, but not clear. So they are
Okay.
like easy 80. So where you're like, oh, I'm really happy with how you're doing, but you're still using a topical once in a while. That's who I see get eczema herpeticum. If they don't do that well, I'm not keeping them on the JAK long term. And if they're totally clear, I haven't seen it. It's in the people who are doing well, but not like spectacular.
Okay.
Yeah.
The last case of eczema herpeticum I had, it was she was a Chinese patient, and she had come over from China where she got upadacitinib, and she wanted to restart it. And I was telling her about Dupixent and this, that, the other, and how it's safer or whatever. So I put her on Dupixent, and she got eczema herpeticum. And then she said, "Why did you give me this drug that causes that?" I was like, "No, this is the opposite." So
Did her
Okay.
eczema get worse, and did she get it because of her, like, with
it,
an eczema flare?
it was one dose of the Dupie, so she hadn't responded yet. Yeah,
So
Okay.
nothing. Yeah.
yeah.
All right. Let's go into our next paper here. So Ferris, I think this one's yours.
Yeah, so this is the utility of IL-23 intraclass switching in the treatment of psoriasis. So this was by Ren et al., and this was in clinical and experimental dermatology. So this was a retrospective paper, it's 43 cases, so there's not a ton of them. The vast majority were switches to risankizumab, so mostly guselkumab to risankizumab, some Tildra to risankizumab.
You're allowed to, Ferris, you're allowed to use brand names. There are plenty of people who are not going to. So
Fine. Switching to Sky Rizzy. Okay, Matt?
There
I
you
don't know
go.
what your deal with
Not
AbbVie is here.
It's not professional.
We're
Stick with the
nothing but
generics.
professional. So
Stick
a
with the
third of
generics.
these were primary non-responders. These were also they were all multiple biologic failures. So these are kind of like the complex patients. Basically, 81% of the time it was successful to switch to another IL-23. And that success was defined as less than 1% BSA. They just looked at BSA. So, I think it's interesting. So I like IL-23's first line. I like that, I like the efficacy, I like the safety, I like the ease of dosing. A lot of times think, gosh, I should switch them to another drug if they fail an IL-23. But now I'm like, oh, I'll just try a different IL-23. And it's still, even though most people were switched to Skyrizi, people who were on Skyrizi and switched to Tremfya also had a high recapture rate too. There wasn't a difference.
I pretty much have always, if you failed one class, I'm going to switch it to a different class.
Yeah, me too.
It sounds like you've generally done the same thing just because intuitively. But so this is going to kind of change your approach.
Kind of. I mean, in the end, like we have that data for IL-17 classes too. So, failing one class doesn't, you often will, still respond to another drug in the same class. I think our gut reaction is it just makes sense, but they are different drugs. They're not all interchangeable. Because I like IL-23s, I think I'm still more likely to say I'll switch from, one IL-23 to another than I am to say, oh, you failed your IL-17. Let me do another one. Let me do another one. Then I'll go to an IL-23.
Okay. Patton, what about you? Do you generally switch classes or do you stick within class?
No, I would switch if they were failing.
Yeah.
Risankizumab, it's also known as Skyrizi. I would say we're going to put you on. Now, I can't even remember what Taltz is called, so I'm going to have to go with Taltz.
Ixekizumab.
Ixekizumab.
Oh, my God. You're a pharma bought and sold.
Yeah.
Exactly.
But, yeah, I mean, what are you going to do next time? Next time Skyrizi fails?
I'll offer him Tremfya, and I'll talk about we can go to a totally different kind of drug, or we can go to Tremfya instead.
And I never gave a damn about this because, right, I do eczema, but now that we've got 3 IL-13 drugs, the data is if one doesn't work and you switch to a different one, it's just as likely to work as if they never failed. It doesn't make any sense. It does not make any sense.
That one's especially surprising, but I do think it's like the Stelara IL-23 inhibitor, right? How could a 12 and 23 that's doing both, how could that be worse than if you're just inhibiting 23?
Did you just say worser?
Worser.
Worse.
Oh, you said
I think I said worse or.
Okay, fine. Okay.
No, I get it, except that there's probably something about the Th1 axis that's impacting the disease. I don't know.
Yeah.
Maybe there's exosomes in it and we don't know it. That's what
Oh, yeah.
All right, Pat. Yeah. Pat, let's go into your the next article here.
All right, finasteride and minoxidil versus minoxidil alone. Of course, they're talking topically. This was Assad et al. In November 2024, Journal of Drugs and Dermatology. Yeah, I mean, this basically the takeaway is the combination is more effective than minoxidil alone. But man, there were just lots of issues with this paper. It said that FDA has approved topical finasteride for hair loss, which is not true. They use SALT scoring for an androgenetic alopecia study, which I would say, like, not do that. Like, that's
never seen that before.
They don't, like, was it, did the patient have to put them on separately or was it combined ahead of time? They didn't really say. So they say that it's more effective. It was 86.7, what did they call it? 86.7 versus 69.1 of the combination versus the monotherapy. I have no idea how they came up with those numbers. When they did the SALT scores actually got worse. Like they increased, which, as we all know, a higher SALT score is actually worse. So, man, I just, if they took the time to do the study, I think that a helpful editor could have gone back to them and said, look, there's a better way to present this data. And it's like, I just thought it was kind of an editorial failure.
I would say first, I agree with you that I think peer review often is lacking to a huge degree nowadays. The one thing that I thought was interesting here, if the data is believable, then the combo worked better on the vertex and the occipital area, but it was no more effective on the frontal and parietal areas. And
they did break it down by areas. Yeah,
was it powered to look at that difference? I cannot imagine that this study. So,
Ferris, stop asking intelligent questions, Ferris.
I want to get that reviewer. That guy never reviews my submissions. Unfortunately.
I,
Yeah.
you know, I I'll use both. I use both systemically. Uh, you know.
Why
Yeah.
not?
Yep. All right, let's go into my next article. So, autonomic denervation dermatitis, the easily overlooked dermatosis. This was in the British Medical Journal Case Reports by Damali et al. Basically, I just want people to be aware that this exists. So, the idea here is whenever you do a transcutaneous excision through dermis, you are cutting nerves and lymphatics, and then you can get a persistent dermatitis as a result of that. The mechanism is not exactly terribly worked out. There are a lot of different ways it could be happening, but why this is so important is the most common setting that you see it in is after a knee replacement, because where they're cutting is right over some of the key cutaneous nerves. And then you can get this persistent dermatitis right over the surgical site. And as somebody who's done a lot of patch testing, I very regularly got patients referred to me because the suspicion was they were allergic to the knee that got put in. And then I'm, talking to them about, well, it's not the knee, it's the surgery, damaged their skin, and the blah, 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 blah. But I had some people who, by the time they got to me, had already had their first knee taken out and a new knee put in because the people thought that this was allergy overlying the implant, which it was, but it really is this denervation dermatitis, and it's just useful to know about this. You treat it like you would any other dermatitis. When I see this, I use some topical steroids, I use some Dermaleave, but it's just important to know that this exists as an entity. Probably not a whole lot of interesting commentary around this. Pat and Ferris, you guys got anything?
I got nothing.
No, I'm glad I know about it now.
Yes, that's it. And I, like I said, I only knew about it because I saw it a bunch of times. All right, Ferris, why don't you tell us about our next one here?
All right, so this was in the New England Journal of Medicine. This is Jed Wolchok et al., and this is the final 10-year outcome of nivolumab plus ipilimumab in advanced melanoma. So, I just thought this is like the final analysis of this incredibly long-term study, and I just thought we should know, the Derms should know about it. So, 3 arms, nivolumab plus ipilimumab, nivolumab alone, or ipilimumab alone. About 315 patients per arm. So, they looked out to 10 years because, as we know, patients can have their melanoma, reemerge later in life. So, when we tell patients, so the question is like, when do you tell patients, yep, that was bad, but you're out of the woods now. So I think we always say, oh, it could come back. So, they looked at overall survival and melanoma specific survival, and definitely the patients who got nivolumab and ipilimumab did better than the patients who got Nivo alone, and both of those groups did better than the group that got ipilimumab alone. Melanoma specific survival, so you did not die from melanoma. Basically, median survival with nivolumab alone 49.4 months. Median survival wasn't even reached for Nivo plus Ipi at 10 years, right? So median survival is 50% of people have died of melanoma, 50% have not. So, it was actually better to get the combination. So you think, well, gosh, 10 years, that's forever. But the median duration of treatment was like 2.8 months in that combination group, about 6.5 months for the nivolumab group alone. And then the thing that I thought was helpful is, can you predict who is going to do well? And so, in terms of at 10 years. So if you were progression free at 3 years, your 10-year melanoma specific survival in the groups that got nivolumab as one of their treatments was over 96%. So if you got, a PD-1 inhibitor, you're progression free at 3 years, you're probably not going to have recurrence of your disease. Also, same for patients who have at least an 80% reduction in their tumor burden. So, early good response may, predict that you're going to do well. And maybe we can start pulling back on the frequency of surveillance or imaging on some of these patients. I know that's more an oncology issue, but our patients ask us about it too.
And so, Ferris, these were people with melanoma that at baseline, at a minimum, they had a positive microscopic sentinel lymph node. So they had
So
some kind of distant disease.
worse disease. So they had unresectable stage 3 or 4.
Wow.
Yeah.
So we could now say to somebody with disease, or they've got a positive clinical, you can feel a lump in their neck. We could literally say to them, hey, most people with your disease live at least 10 years.
So
Right? That's technically accurate, correct?
yeah, with the treatment,
With
with,
therapy, yes.
particularly we saw that in the nivolumab and ipilimumab group. Now, this is all kind of outdated because if you have a patient, we treat things differently now. We've got different combinations. We've got neoadjuvant therapy that works even better. So this group, if they had stage 3 disease, they would have had their lymph nodes removed and then would have been treated. Now we know if you, give people a couple doses of immunotherapy, then remove their lymph node disease, they do even better than this. So it's good to know the data, but it probably is not exactly how we're going to be giving care over the next, how we're going to be treating patients over the next 10 years. But yes, these are people with advanced disease. The patients who, when we were residents, were like, oh, they're gonna die.
Yeah, the death
before we
sentence.
had these therapies. Yeah.
The death sentence. Yeah, I mean, I've got one guy who he got his initial diagnosis was a met to his brain, like just collapsed one day, had a seizure, never found a primary on him. He got immunotherapy, widely spread metastatic disease, got immunotherapy. He's now been my patient like 7-8 years, doing great. And I'm like, good, like it's just shocking to me, but I guess it's not that rare to see that now. Huh.
Yeah.
All right, so Pat, why don't you give us our last one here, which is one that is actually pretty darn interesting to me.
All right, then. Topical steroid withdrawal is 2 papers. First one, Alsterholm et al. In Acta Dermatovenereologica, January 2025. It was a questionnaire through a Facebook group of patients who had TSW, and they just kind of, I think, wanted to learn more about topical steroid withdrawal. So it was kind of odd because most of the patients that answered the questionnaire basically self-diagnosed topical steroid withdrawal. They didn't have like a physician diagnosis, which I kind of get because we don't know how to diagnose this. I think some, the patients who have this do express a lot of nobody believes that this is a thing, and so I'm not even going to go to my doctor. So I think they just kind of wanted to get the authors wanted to get more information. Figure 1 kind of shows all the things that summarize most of the findings. They describe the common signs and symptoms: erythema, itching, burning, sleep disturbance, dryness, peeling, oozing, etc. And then they also reported triggers, mostly topical steroids, how often it occurred, and the impact that it had on their life. So we know a little bit more.
So after Article 1, this article, do you think it's a real thing?
I do. No, I do, but I also think that, a lot of these sufferers are kind of like, physicians don't believe me. Well, if you walked into my office and you said, I have a history of atopic dermatitis and it's really bad, and I used a steroid, and then I stopped the steroid and my face got itchy, red, scaly, you couldn't fault me for saying this could just be your atopic derm. Yeah, this could just be your atopic derm. And the fact that, it's like, well, we don't believe them. I'm more than willing to accept that this is a thing, but how can we diagnose it? I have no idea how we differentiate it from other things that it can be. So how do we diagnose this? I mean, do you believe it?
I didn't for a long time, but then the second paper here, the topical steroid withdrawal is a targetable excess of mitochondrial NAD plus, by the senior author, this guy named Ian Miles at the NIH, who was brilliant. He actually did show that there are some pathophysiologic mitochondrial alterations that they were able to define in the lab. So I do now think it's a real thing, but I still have exactly what you said, no idea how to differentiate it from your eczema flared versus you got addicted to topical steroids and we withdrew it. I mean, the other thing is periodermatitis that is induced by topical steroids. Like, we all would agree that that is a real entity, and it is in many ways different from regular periodermatitis with no history of steroid application. So to me, that also adds my clinical evidence of that's an entity I know for sure is real. And so it makes sense to me that pathophysiologically this is out there. But yeah, I still don't know how to differentiate the two. I don't. Yeah. Yep.
I don't either.
What's that?
Yeah, I don't know how to differentiate it. So what do you do? I mean, how are you going to treat this?
So
I think if, you could say, I don't know if this is your atopic dermatitis flaring. I don't know. Maybe you're using a face wash. Maybe this is allergic contact dermatitis, which is going to flare pretty badly once you take steroids away. And throw in the possibility that, okay, this could be topical steroid withdrawal. We don't really know that much about it. That's really hard to treat. I mean, honestly, I've learned the most about topical steroid withdrawal by just going on these blogs and reading about these patients, and you're kind of like, all right, yeah, this does behave differently in the way they got it to go away. Did they just get better? Did they have less stress in their life and all of a sudden their atopic dermatitis get better? Because I've seen stress cause atopic dermatitis to go crazy. So, reading those individual things, I'm buying it's a real thing, but I think patients have to be a little bit understanding that we don't know how to differentiate these things.
Yeah.
That second paper they went through, right, all these different studies. I didn't understand 90% of that paper. A couple cool takeaways. They offer maybe a diagnostic tool. So they put together major and minor criteria, 3 major, 9 minor. If you have 1 or more major and 3 or more minor, that was 90% sensitive. So the major, burning, flushing, thermodysregulation, I don't really know how that's defined. And then the 9 minor, I'm not going to go through that, just other symptoms. So maybe we have a tool. The takeaway was that TSW happens because, quote, there's increased expression of mitochondrial complex 1 and conversion of tryptophan into kynurenine metabolites. There it is.
Yeah.
So now we know.
Obviously.
And metformin and berberine, which is an ingredient in traditional Chinese medicine, may be therapeutic options. So, Matt, you have another reason to give everyone metformin.
Give everybody metformin. So, thanks for joining us this week. If you've got questions, comments, or ideas for topics you'd like to see us cover on the show, shoot us an email at questions@dermsondrugs.com. Again, questions, just the word questions, at dermsondrugs, DERMSONDRUGS.com. I hope you learned a few things, hope you laughed once or twice, and I hope you're planning to join us next week. And I do have to tell you, next week is going to be kind of a mind blower for you. So we're going to have a guy on named Richard Weller, who is a dermatologist in the UK, who has done some amazing work that really suggests that all of the sun protection that we're telling patients to do to prevent skin cancer may actually be substantially increasing the rates of heart attacks and cardiovascular death. So it may be that we are preventing skin cancer by telling our patients to stay out of the sun, but we may be increasing the rates of heart attacks and strokes and things like that. And I will give you the heads up, it has nothing to do with vitamin D. Totally different mechanism. You cannot give people vitamin D to counteract this. So anybody who says that, tell them instead of sun, but take vitamin D, means they don't know what they're talking about. All right, so I can't wait for Dr. Weller to come on and really see if he can convince us that this is real, and maybe we've been overplaying the sun protection card. So join us next week for what is going to be a really cool discussion. And until then, I'm Matt Cyrus.
I'm Tim Patton.
And I'm Laura Ferris, and we are Derms on Drugs.